Everyone, I'm Ayush. I'm a rising senior at Berkeley, where I'm studying molecular biology, and I'm also a volunteer at the Berkeley Free Clinic, and I'm researching HIV in human brain tissue at UCSF. So getting to do some super cool things. And I guess my reason for why I'm here today is because I'm passionate about care and advocacy for queer patients. I think in medicine, sometimes we don't realize that regardless of what specialty a physician is, practicing or specialized in, you will always see queer patients, and we can always work to make their experience in healthcare a little bit more welcoming and, I guess, culturally sensitive. So yeah, I'm currently studying for the MCAT for my retake and then planning to apply to med school next May. So looking forward to that. And I'll pass it off to Wayne.
Hi everyone, I'm Wayne, your other co-organizer here. I use any and all pronouns. I'm a UCSD graduate this year, 2024, and currently applying to medical school right now. Secondaries are coming back. I'm a volunteer on the North County Gender Advocacy Project Health Committee, which connects transgender patients to critical health resources. And in the future, I hope to be a pediatrician so that I can help out trans kids.
Right.
And we organized this webinar because both of us are queer pre-meds who are dedicated to creating a more inclusive, accessible healthcare environment for LGBTQ patients. Like Ayush mentioned, regardless of the specialty that we see ourselves as having, we will definitely be seeing queer patients, and we want to make the clinic a more inclusive place so that patients of all sexualities and genders can receive healthcare in a judgment-free zone. We also want to advocate for bodily autonomy because the issues affecting the proper healthcare access for transgender and intersex individuals are also the issues intertwined with reproductive justice as well. We want to be able to provide the opportunity for these individuals to have an informed choice in their healthcare treatment, and for all patients, especially queer patients, to have access to these healthcare services in the first place. We also want to promote an equitable healthcare system that can acknowledge the intersectionality among patient populations. Some resources that I wanted to send are the LGBTQ Task Force's resource for queering reproductive justice, because LGBTQ issues on equity, accessibility, and justice are intertwined again with reproductive justice. I also wanted to send some information about intersex health because while unfortunately we don't have the room to discuss intersex healthcare, I still wanted to emphasize that these issues of bodily autonomy are very important to learn about. So I'm sending a few links, and they'll also, along with the slides, be sent out after the presentation.
Awesome. Thank you, Wayne. And then I just wanted to give a big shout out to our moderators, Dr. Bryce Smithson and Dr. V. Thuy Nguyen. They both have kind of helped organize the event, and they're amazing. They're both pediatricians at Kaiser, and this wouldn't have been possible without them. So thank you to both Doctors Nguyen and Smithson. And then there are their bios. They're doing some amazing, wonderful things, and I encourage you to read about what they're doing and look into what they're passionate about. Yeah.
On to our presenter bios. Like the slides, like all our information, these bios will be sent out at the end of our webinar. Dr. Celebi, along with Dr. Hudda, are going to be presenting on sexual and gender minority health from the primary care perspective. So Dr. Celebi is an associate professor of family medicine and public health. And on the next slide, Dr. Hudda will also be presenting on sexual and gender minority health and is a resident physician in the Department of Family Medicine. Thank you so much to them. They will be presenting immediately after our introduction. Dr. Jordan will be presenting on diagnosing dysphoria and is a clinical assistant professor of pediatrics.
All right. And then Dr. Chen is a reconstructive urologist, and he specializes in masculinizing genitourinary surgery. So today he's going to be kind of giving an overview of female to male surgery. So yeah, that'll be the second portion of our presentation in the breakout rooms. So we're really looking forward to that. And then to kind of go over what today's agenda is going to be like. So 10 to 10:15, that's what we're in right now. So that's our little welcome. And then 10:15 to 11, we're about to head into that portion. It's going to be Dr. Celebi and Dr. Hudda's presentation on sexual and gender minority health, as Wayne introduced. And then 11 to 11:45, we'll go into breakout rooms where Doctors Jordan and Dr. Chen will be presenting on diagnosing dysphoria and the overview of female to male surgery. And then at the very end, we'll have a little sign out. There's a form because this webinar is essentially, I guess, sponsored by Kaiser. There's a form for the CME credits if that's something you were interested in, and we'll do a sign out at the very end for that. So yeah, I think we can get into Dr. Celebi and Dr. Hudda's presentation.
All right, let me just share my screen real quick. Okay, can we see my screen with the slides? Okay, perfect. Great. Hello, everyone. It's lovely to be here. Special shout out to Ayush and Wayne for organizing this amazing space to have this discussion. These spaces are very much needed, not just for informative purposes, but also for people to feel welcome and invited and feel as though they matter in terms of healthcare, which not, especially being a resident, is not often the case. My name is Rahil. I'm one of the resident physicians and chief residents at the UC San Diego Family Medicine Residency Program. And with me, I have my lovely mentor and attending Dr. Celebi, if she wants to say hi real quick.
Hi, nice, happy to be here. I'm letting Dr. Hudda mostly run the show here, but I'm here for support.
She's just as, if not more important. All right, so just to make sure that we have enough time to go through all the exciting things we have to talk about, we'll get started. So our talk today is sexual and gender minority health from the primary care perspective. There we go. We have no disclosures. Happy San Diego Pride Month, everyone. Objectives. So you can read it off the slide. We're just going to be kind of talking about some broad strokes in terms of things to look out for with this population from the primary care setting. We'll talk about some terminology. We'll talk about some evidence-based preventative care strategies, and really just what the role of a primary care provider is with this amazing population. So I'd like to start with this quote by Barbara Giddings. Equality means more than passing laws. The struggle is really won in the hearts and minds of the community where it really counts. So let's start with some terminology. Before I start this slide, I'd just like to say that what me and Dr. Celebi are going to discuss today is not cumulative and not fully encompassing of the importance of what this community needs and deserves in terms of providing healthcare. Our goal today is to really do some broad strokes, to touch on some broad topics, hopefully transfer some key takeaways and pearls for everyone. But this does not by any means encompass every single thing. So terminology. So biological sex. What's biological sex? So this is based on physical characteristics. About 1 in 100 to about 200 births result in a child whose body differs from the, quote, standard male and female. About 1 or 2 in 1,000 people have surgery to normalize the appearance of their genitals. And about 1 in almost 2,000 births result in a child whose genetic makeup is neither XX or XY. Many transgender people prefer the term assigned sex at birth. It's a more inclusive term and is often a term that we will use when a patient first comes to us when we're trying to kind of identify their preferences and where they lie. And we'll get more into that in a second. Gender identity is the next term, and this is basically the psychological sense of oneself. So a person's gender may or may not coincide with their biological assigned sex. Some people identify as neither, some people identify as both. Terminology that can be used with these categories are more queer or gender queer because they're a little bit more inclusive. Some things to know is that different cultures have different gender categories, right? The Western world, we're very polarizing and we're very, male or female. But a lot of cultures that are not Western, since early years, have cultures that have have categories that are in addition to male and female. And then it's important to remember that gender is a social construct. Always remember that. Gender expression. Gender expression is any and all mannerisms, personal traits, etc., which serve to communicate a person's identity and personality as they relate to their gender and their gender roles. This can be present in people of any sex or any gender identity, and it can be very fluid as well. There isn't just one category or one subgroup that one has to identify or take on stereotypical roles of. Gender, like the previous term, is also culture specific. A trait or behavior that reads as male or masculine in one culture may actually be seen as more female or more feminine in another type of culture. This, we're touching on these things because it further emphasizes the role of intersectionality and how intersectionality plays with patients, both in terms of their gender identity, their sexual orientation, but also their upbringing, their race, their ethnicity, so on. And it's important to note that an individual's gender expression may vary from day to day, from year to year, or even from one social context to another. The way that I might present my gender expression within this space that I know is a safe space for me may be a little bit different than when I'm on a rotation or working with other physicians or working in a different space that may not be as welcoming for me, which is a conversation and critique in and of itself, and we can go on and on about that, but we'll save that for another day. And then there's sexual orientation. So this is a term that refers to the emotional, romantic, or sexual desires that one person may have for another person or even group of people. Some examples of sexual orientation are gay, lesbian, heterosexual, bisexual, pansexual, though there are numerous others. For me, I'm a very big visual learner, and me just talking at you all may not be something that you all are receiving. So as we go on through this presentation, you'll see a lot of diagrams. This is one of them. And this touches on the different sexual orientations that a person can take on or a person can identify with. And some of them I just talked about, but I'll let you all go through this when we send out the slides. This, excuse me, and the next slide are kind of two of my favorite slides here. This is the gender-bred person, which basically summarizes in one pamphlet everything that I just talked about in terms of terminology. So this is the good one. I personally like the gender unicorn a little bit better. It's a little bit more fun. Who doesn't love a unicorn? But also it's a little bit more streamlined and easy to digest, at least in my opinion. This is definitely something that the pediatricians I've worked with, they love using these because it's a very clear, concise, and inviting way to talk about these different terms with their pediatric patients. But also, I have a lot of colleagues and attendings in my program who have this put up in their offices and in their clinics because a lot of people just don't know the differences between all these terms. Or may not have ever been exposed to them. So this is a really good way to kind of break that ice when talking about these things, which we encourage you all to do, especially when you become physicians, for those who have not reached that space in their life yet, and you're meeting patients for the first time. The next thing we wanted to talk about is pronouns. So pronouns are extremely important. They are an extension of our identities and are just another way for us to really feel confirmed and affirmed about who we are. It's a way to create a safe space and setting a mutual respect and understanding. And the thing about pronouns is that there are a lot of easy ways to present your pronouns and to kind of normalize the use of them. For example, I see that a lot of us here in this meeting have our pronouns listed next to our names, underneath our videos. I know that Dr. Celebi and I in our clinics, we have pronoun badges or pronouns listed on our name tags. And this is something that I do with all of my patients, especially when I meet them for the first time in clinic, asking them along with, the other identity questions that we just talked about, what are your pronouns? And Epic, if you use Epic, has the ability for providers to enter in pronouns. And I would encourage everyone to do that. I'd like to take just a second to acknowledge that mistakes happen. Even when we, as people in this space who are very wanting and dedicated to creating these safe spaces and to creating a world where sexual and gender minorities are being focused on in terms of their health, that we often sometimes will misgender people. And it's important to acknowledge what happens, to apologize, and then to move on from that example and hope that it doesn't happen again. Yeah. Language is really, really important, especially when working with sexual and gender minority health populations. It's important, like I said, to really, when you're meeting someone for the first time, to kind of break the ice and break those boundaries. So when, for example, things that you can ask when meeting someone for the first time is, hey, like, what name would you like me to use for legal or insurance purposes when we're filling out paperwork, when we're signing forms? What pronouns would you like me to use? And then, for example, are there words that you would like me to use for your specific body parts? Because not everyone likes using the traditional penis and vagina and so on for their anatomical parts. Another thing that I personally like to really focus on with my co-residents and the medical students that I work with is really trying to use gender-neutral terminology. Oftentimes, these are things that get lost or we just don't realize that we're doing. But for example, when we're addressing a group of people, we'll often say, "Hey guys, like let's do this," or "Hey guys, how are we feeling?" But that's a very gendered term. So instead of using guys, you can use y'all or you all. I promise that you don't have to be from Texas to use y'all. Using they, them, their pronouns, especially when you don't know someone's pronouns, or they haven't endorsed them to you yet, is a great way of using using that as like a neutral term. Using the word partner instead of boyfriend, girlfriend, wife, husband. And I know that this can be coming from a place of respect, but avoiding sir, avoiding ma'am, avoiding Mrs., Mr., unless you know exactly where that person lies, because that is a pretty gendering term, even though it comes from a place of respect. We also want to talk about some disparities today, and I know that some of my the other providers who are going to be speaking today will probably touch on this, so we won't spend too much time. But it's really important to note that gay and bisexual men and transgender women are at higher risk of HIV and other STIs. Lesbians and bisexual women have a higher rate of ovarian and breast cancer relating to null parity, meaning that if they haven't gotten pregnant. Exogenous hormone use, especially within our trans population, may lead to higher risk of cardiovascular disease. The sexual and gender minority health population also has lower rates of preventative cancer screenings. You can imagine that this population often doesn't feel safe or comfortable going to the physician unless it's absolutely needed because of negative experiences, which I'm sure a lot of us even have experienced. And because of these lower rates of obtaining and accessing medical care, it shows in health outcomes. So for example, in 2009, a survey of almost 5,000 sexual and gender minorities found that 56 of LGBT patients and 70% of trans patients reported being refused needed care health providers refusing to touch them or using excessive precautions, or providers being rough or abusive, both physically and verbally, or these patients being blamed for their health status. So you can just imagine how awful this is, both to experience, but as a whole for the population that we're here to talk about today. Some more disparities. So intersectionality is something that I briefly touched on earlier, but SGM people of color specifically are statistically less wealthy than their white counterparts. They have higher rates of poverty, and they're more likely to be target of hate crimes, experience housing discrimination, experience food insecurities. And because of the history of all of this, it can lead to a lack of health insurance and therefore not being able to access the medical care that not only that they need, but also preventative medical care. Mental health is something that primary care loves to talk about and is a huge focus, especially within this population. LGBT adults are more than twice as likely to experience psychological distress. The LGBT adults are more than twice as likely to need medication for emotional health. When we look at the younger population, LGBT youth are more than 3 times as likely to attempt suicide than their heterosexual cisgender peers. And LGBT adults are more than twice as likely to consider suicide. And these are all statistics, these are all facts, these are all from studies, and you can access, those studies from the links that are at the bottom of the slide. But it's not a small difference. It's huge, and it's sad to see and needs to be addressed. So let's talk about health maintenance. Health maintenance is something that primary care focuses on. That's our job, right? That preventative care is what we live for, what we breathe and thrive on. And it's the term that we use is healthcare maintenance. So one of the things that we like to do in primary care is cancer screenings. When we look at the sexual and gender minority health population, it's recommended that a mammogram to assess for breast cancer or unstable breast growth is recommended every 2 years for trans women greater than ages 40 to 45 who have been on hormone therapy for 5 or more years. The standard of this for cisgendered women is every 2 years as well, starting about age 50, regardless of hormone use. And when we look at prostate cancer screening, it's the same guidelines as cisgender men, but we do have a lower threshold to test if there's any inclinations that something may be wrong. When we look at cervical cancer screenings, it's the same thing as non-transgender women. You start doing pap smears at about the age of 21, and depending on what type you're screening, it's either 3 or every 5 years. Something that's really specific or touched on or should be focused on within the sexual and gender minority population, but with anyone who partakes in anal receptive intercourse, is anal cancer screening or something called anal paps. A lot of primary care providers or providers in general who are not familiar with this population don't know about this. And it's definitely something both for your current patients, future patients, and even yourselves to be aware of that if you're partaking in anal receptive intercourse, it's important to be doing anal pap smears or anal cancer screenings to assess for anal cancer. When we look at vaccines, obviously the normal vaccination protocol that's recommended by the CDC is important to enforce, as it is for any patient. But some things to look out for and focus on with this population is the Mpox vaccine, the meningitis vaccines, the hepatitis vaccines, both A and B, along with HPV. And then the other thing to look out for and to be aware of is DEXA scans, and this is basically the bone density scans. The standard protocol is at age 65 and older, you're doing a routine DEXA scan for all genders, no matter what their history is, what their experience is. If you have patients who are on androgen suppression, it's important that once they hit age 50 to 64, you're doing DEXA scans. And then if you're on 5 or more years without hormone replacement therapy after gonadectomy, meaning that your gonads have been removed. The thing about DEXA scans also is that I'm sure that my pediatrician colleagues will touch on this, is that the studies that are out there they're not a lot out there. So I know that a lot of people will, do DEXA scans at different ages and at different years and based on different experiences. So the information and the studies are constantly improving, constantly being evolved. So this is just like anything in medicine, important to be aware of. The other thing just to touch on is here, I have in red, is it's important to do an organ inventory and screen the organs that an individual has. So if you're unsure of what to screen, how to screen, when to screen, the first step is to do an organ inventory. This is often done, at least for me and Dr. Celebi, when a patient first arrives and establishes care with you. And what that means is that, for example, if you have a trans patient, let's talk about what organs you have. Have you partaken in bottom surgery? Have you partaken in top surgery? Have you had any other surgeries that are involved? What organs do you have, so that we're aware? We can put it in the chart so that just in general we're aware, but also when the time comes, we can screen those specific organs. Let's talk about more prevention, both specifically in the space of medication. So let's talk about PrEP. PrEP stands for pre-exposure prophylaxis and is a medication that you can take to prevent HIV. There's different forms of it. The oral form that we'll talk about today is Truvada and Descovy. And the long-acting injectable form at the bottom of this table is called Apretude. So the most common one that I see is used is the oral form of PrEP, either Truvada or Descovy. It's a pill that you take once every single day, and basically prevents up to 96% of times, and from the studies that have been done, prevents HIV from being obtained. The important thing with this that we'll briefly get into, but won't focus on too much, is that it's important to screen the patient in terms of how their general labs are and adherence. These are one of the things that you have to take every single day for it to be effective. We'll talk about a specific form of PrEP with Truvada in a second, where you don't have to take every single day, but the CDC does recommend that the best way to take Truvada is once every single day. Apretude is a long-acting injectable form of PrEP. This one is really good for people who are not able to remember to take pills every day, people who are experiencing homelessness and don't have that good follow-up to care, or often have issues with their pill bottles being lost or stolen. And this also can be helpful for your younger population who don't feel safe having pill bottles for PrEP at home. For various different reasons. The thing to remember is that Apretude, since it's still new, insurance doesn't always cover it. So that's a conversation to have and something to be aware of with your patients. So target populations for PrEP. The main ones that we'll focus on, or we'll at least address today, are men who have sex with men, heterosexual women and men, and injection drug users. The recent studies have shown that because of a lot of the work that we've done and people have done focusing on the MSM population, the highest incidence of HIV actually now is within heterosexual individuals and not men who have sex with men. So it's important to remember not to just focus on your patient population who is queer or your MSM population, but to focus on all of your patients. Ask your patients about their sex history. Ask them how many partners they have. Ask them what genders they partake in sex with, and ask them if they partake in anal sex, vaginal sex. It's important to have these conversations and to normalize having these conversations, both within a primary care setting or within any type of healthcare setting that's applicable. So this is a PrEP follow-up, PrEP visit checklist. I won't get into this too much since this talk is more geared towards our lovely pre-medical population. But this is a really good chart to look back at and to reference in terms of kind of timelines for when you start prep, what initial labs you need to do, when they follow up in a month, what labs you should do, and then how often they should return. Basically, individuals who are on prep should return every 6 months to have their STI labs done, have their HIV test done, to follow up on their kidney functions, because oral PrEP has known to maybe affect creatinine levels or the levels that assess for kidney function, and to talk about mental health and adherence. It's important to talk to your patients, important to see what they're experiencing, what they're going through, and ways that you can assist them, not just in providing a medication. On-demand prep. So this is something that I do want to focus on real quick. On-demand prep is a type of prep that you can take not every single day. So this is helpful for people who are not able to take prep every single day, or people who are really uncomfortable or don't want to be taking a medication every day, especially amongst people who don't partake in risky, quote unquote, risky sexual health behavior on a regular basis. So if you have a patient comes in, they don't want to take prep every single day, but once a month, once every 2 months, they have a weekend where they partake in sexual intercourse with one or multiple partners without using protection, this could potentially be a good option for them. Basically, what you do is that on the first 24 hours prior to partaking in anal or vaginal intercourse, you have the patient take 2 pills of Truvada. About 2 hours before or 2 hours after or partaking in intercourse, you have them take 1 pill of Truvada, and then 48 afters of being done with having intercourse, whether that's been going on for a few days, as it shows below, or just a one-time thing, you have them take 1 more pill. And that's what 2-1-1 means. You take 2 before, 1 during, and then 1 after. And this is shown to be just as effective as taking PrEP every single day in terms of preventing HIV. The important thing to note is that this has only been studied with Truvada, not Descovy. So if this is something that you're interested in providing or talking about with your patient population, it's important to remember that Truvada is the form that you would prescribe. Post-exposure prophylaxis. So PEP is another term for this. And this is the medication for possible exposure to HIV after the fact. So it's almost like a plan B for HIV exposure. So for example, if you have a patient that comes in and says, "Hey doctor, I had unprotected intercourse last night. I'm not sure if my partner has HIV," or "Hey, I just found out that he actually does have HIV. We didn't use protection. What do I do?" This is the perfect thing to provide for that patient. The important thing to note is that it must be started within 72 hours of the exposure. That's when studies show that it's the most effective, and it's a medication that you take for 28 days. So you start it within 72 hours of a potential exposure. You take it for about a month. This is really good, and we've seen it with individuals who are victims of sexual assault, who've partaken in unprotected vaginal or anal intercourse, who have partaken in needle sharing, and individuals who have had workplace exposures, such as needle stick exposures. Another thing that I forgot to put in the slide, but I had a lovely participator at a different conference we talked about. It's really good for your kink population as well. So people who participate with different types of toys that can cause skin breakage, and potential blood exposure. This is also something to keep in mind if that individual isn't on. I like handouts, like I said, so I won't talk about this, but this is a lovely little diagram that I got from Healthline that compares and contrasts PrEP versus PEP. DoxyPEP. I love DoxyPEP. This is a newer medication and a newer study that was released. And DoxyPEP stands for doxycycline post-exposure prophylaxis. Doxycycline is a type of antibiotic that's used for gonorrhea, chlamydia, and syphilis infections. And what this is that for individuals who partake in large amounts of unprotected intercourse or have a high history and high incidence of having STIs, this is something that you could prescribe to them. So the individual basically takes 200 milligrams of doxycycline within 24 hours, but no later than 72 hours after having condomless anal, genital, vaginal, or oral sex. You want to encourage the patient to take it with food and water more than 1 hour before bedtime. You want to make sure that they don't take it more than 1 to 3 times a week. And this is basically shown to significantly decrease the risk and decrease the rate of gonorrhea, chlamydia, and syphilis by almost 70% in the populations that are using this medication. The thing to know is that this is not a substitute for STI testing. So it's still important that a patient comes in, gets STI tested, gets tested every 3 months, gets their HIV tested if applicable. But this is a really good option to share with your patients or to just be aware of if you fit kind of this category. I see a lot of chats popping up. I'll address everything at the end, I promise. This is a little handout about DoxyPEP if you're interested in kind of knowing more details or sharing with your patients or your colleagues. And then we'll kind of transition over to gender affirming care. So I'll let Dr. Celebi take over and I'll have her let me know whenever she wants me to change slides.
Sounds good. So yeah, gender affirming care, just want to drill down a little bit more about what this can look like. So I know a lot of times people kind of really jump to hormone therapy, that's what people think of when it comes to gender affirming care, but there's such a constellation of things that we provide in primary care and that we can help facilitate referrals for patients. So I think really thinking about these different categories of, mental health being so fundamental, given all the disparities that Dr. Hudda was talking about. Surgery is sometimes part of the story for patients. Voice therapy, I think, is also to be something to be aware of, that speech therapists can be really helpful to kind of help people meet their goals there. And then I think really making sure there's good social support. And I think a lot of folks feel like, oh, I don't feel skilled enough in this area, so I can't really provide gender affirming care. But I would argue that just simply being skilled and humble in a lot of even just the language and the communication and all of that Dr. Hudda was talking about at the beginning, that is providing gender affirming care simply by showing up that way for your patients. So just wanted to really emphasize that. Next slide. So the gender health program that we have at UCSD is a great example of kind of a really nice wraparound support service that we have available to gender diverse patients. I think that the idea of having really a network of people who have sort of bought into how we can support patients who are, not in the typical binary and looking to be affirmed through a gender transition is really important. With 1/3 of transgender folks reporting having a bad experience with a healthcare provider, we need to really make sure that we have good support set up. Through our program, we do have a trans care navigator, Rai Kamisa, and they're amazing. And I think that idea of really having people who can be advocates for you and help you navigate all of the different pieces that can come into the journey is really crucial as well. So yeah, let's go to the next. So when I think about gender health, I really want people to feel, I'm biased and Dr. Hudda is biased too, as primary care physicians. We totally believe that gender affirming care and providing gender health can be 100%, a part of our armamentarium of things that we provide. The more we sort of make barriers to getting people care because we don't feel comfortable, that's just providing, contributing to more disparities, you know what I mean? So really, the fact too, that when a patient can have a really strong primary care physician relationship, that trust, that continuity, that longitudinal care, it really can just decrease the barriers to care in so many ways. So, everybody sort of has their different comfort level of how much they might provide in the gender affirming space in terms of like hormones and things like that. But I think as much as we can try to be equipped in primary care to provide a lot of the support, that we're improving outcomes for our patients. Next slide. So this comes out of the standards of care for the health of transgender and gender diverse people. This is the latest version, version 8. Sorry for the text being a little overlapped, but basically you just need a master's degree to be able to assess a patient, to figure out if they have are meeting criteria for gender dysphoria. You don't need to go through years and years of fellowship or things like that. So pretty much anyone who goes through medical school and, you know, is now as a physician, you can be a person who can do some of this assessment to help people get started. And the idea behind hormone therapy is that really if someone has a sustained sense of, you know, not of wanting to transition to a different gender, that hormone therapy is a good option. I mean, obviously, if someone's just coming in for the first time and they're like just starting to think about it, that's not something that you would jump to. But most of the time, that's not even the case. Most of the time, patients have been dealing with this for years and they're finally, you know, building up the courage to come in and have the conversation. And so most of the time, this is not even an issue, but just really that's sort of where hormone therapy is recommended for people who kind of have an ongoing you know, feeling of gender incongruence. Definitely making sure, you know, as primary care physicians, we really think about, you know, the whole person. So making sure all the physical and mental health conditions are optimized. Some of these medications carry certain risks. And so if there's cardiovascular risk factors and things like that, really making sure we're doing a good job of optimizing those things, making sure blood pressure is controlled and, you know, mental health, making sure that mood is well managed with medications, therapy, et cetera, that all of that is part of the picture. And then there's a general recommendation that before considering, you know, irreversible surgical intervention, to consider 6 months of hormone therapy. I feel like this is like does not apply for certain folks, you know, maybe, you know, someone who's non-binary, who just has a lot of dysphoria, like menstrual dysphoria, and they want to have a hysterectomy, but otherwise are not interested in hormones, then that's sort of a different situation. But basically, if someone's kind of considering both in their path, that usually you're going to want to do the hormone therapy for that amount of time before you pursue the surgical interventions. And then just other things to be aware of is the fertility preservation before you pursue some of these things, and having those conversations so that people are aware that there will be an effect on their fertility when you're pursuing some of these therapies, and also where they are socially, what kind of support they have in terms of being able to transition at work, at home, what's the family situation. All of those things are really important, because even if they're like, they know in their heart they want to transition, there might be safety issues or discrimination concerns. So really getting at that is important to have in the discussion. Yes, so Dr. Hudda went through kind of some of the disparities generally for LGBTQ. I would say one thing to be aware of is the suicide rate is horrifying. You know, I think he said it was 2 times for LGB in general, the general population, but for transgender people, it's the suicide attempts are over 10 times the national average, which is just shocking. The fact that 40% of people have attempted suicide, like that is just mind-blowing to me. So obviously you don't want to ever assume, oh, this person is gender diverse, they're obviously have depression and anxiety. There's a lot of people who are fortunate to have really supportive, you know, situations where they are their mental health is really good, but just clearly there is such a high rate that you really need to do a good job of screening and making sure that you're managing that well. And then just rates of tobacco, alcohol, drug use. So really just screening, obviously not assuming that that's a problem, but just being extra mindful to be checking in on any that as part of the social history. Next slide. And we don't need to kind of get too into the weeds with this, but just so that people have this as a reference, these are some of the things that are available for hormone therapy. So if you're kind of in the transmasculine route, testosterone is often done in the IM or often sub-Q. It's not FDA approved for that, but it has been shown to be pretty much equivalent. And generally that's on a weekly basis to avoid sort of the dips that you can have if you go longer, more in the every 2 weeks that some of our, you know, cisgender men use. Gel and patches are available, but I think a lot of people just find that to be a little bit more challenging to navigate. And the goal range is generally just what the reference ranges are for what their affirmed gender would be. So being mindful of that. And then also, oops. And then basically labs are about every 3 months. And these are some of the ones that you look at, just thinking about some of the cardiovascular risk that comes with testosterone, to be mindful of that. So A1C is looking for diabetes screening, and looking at the complete blood count, mainly because you can get elevations in your hemoglobin, hematocrit. So those blood counts, if they get to be at a certain level, then that we're a little bit more worried about clotting risk and things like that. For trans feminine, kind of thinking about the 2 categories of the anti-androgens. So spironolactone is the common one that we'll use, just a pill. And then estradiol can come in different forms, oral, transdermal. Usually transdermal is recommended just in terms of decreased venous thromboembolism, cardiovascular risk. Though, some people can have concerns about, wearing patches and being more open about, the fact that they are transgender. And so I think you just have to be mindful and tailor it to the patient's goals. Next slide. And then I think Dr. Hudda talked a lot about this in terms of just remember there's a spectrum and the fluidity, and just checking in with the patient often about where they are and not making assumptions about where they want to go in their gender affirmation. There's definitely a lot of stress, and I think this came up actually in one of the conferences that many of us went to recently. That idea of kind of non-binary erasure and like lack of understanding, like because in our Western society we tend to be so like just one or the other, black and white, that people can get really confused and not really understand how to show up the way that non-binary patients need, and then those patients end up having to do a lot of education of their clinicians to help them understand what they're, how to call them, what they're looking for. And it's just, I'm sure, incredibly exhausting. So I think just that idea of really educating yourself, and it's good to be sort of open and humble and curious in terms of trying to meet their needs, but not to the point of like, oh, teach me everything and that's not the patient's job. So we need to own our ability to be able to work in that fluidity. And kind of talked about this a little bit of like the medical and social transition that can be a little bit variable between, how people can present and their gender expression and stuff, between like work or, places where they feel more safe. So, and just, I mean, there's a lot of nuances of hormone therapy. Some people have different goals. So, sometimes we kind of start low, go slow. It really just depends on how much, and so having those conversations with patients about what they're hoping for, but also trying to curb expectations a little bit in terms of what can be achieved. Sometimes one of my colleagues recently was talking about like sometimes people are like hoping for a full beard, but if it tends to run in the family that like your male family members have like patchy beards or like that, you're probably not going to get that full beard. And so really just helping people to understand what that can look like. And I mean, just anytime we're starting hormone therapy and there's good informed consensus about this, talking about some of these risk factors about impact on cardiovascular risk and bone density, and mental health is just important to mention. Next slide. I know we're kind of getting close here, so I'll just try to be quick. So won't dive deep into this because again, this tends to be more in our pediatric endocrinology colleagues manage this. We tend to manage more hormones in the adult population, but to be aware that there are these medications that can kind of delay puberty, and that's something to be aware of, that fertility preservation is something to be aware of. And just to know that patients, I mean, of any ages, but sometimes we'll see this more, especially when younger people are limited in what they can do for their journey. Just chest binding, tucking, those are important to be aware of, and that there's ways to kind of do it a little bit more safely, and that similar concept of doing hormones before any definitive surgeries. And actually it's for a longer time of 12 months instead of 6 months in general. And then I think kind of we went in, Dr. Hudda went into a lot of this already, but just focusing on body parts, being mindful of language, let the patient kind of lead the way on that, being really sort of non-gendered and not making any assumptions when you're talking about sexual history too, sort of not saying like, are your partners male or female, or sometimes you even just say like, what, like you just have to get really nitty gritty of like, what parts go, you know, in terms of instead of saying, oh, I have male partners, but that male partner may be transgender. So I think just really being cognizant of the ways that you can ask about sexual history in a really open way. And I think the more you just ask open-ended questions, like tell me about your partners and things like that, then you can get the information you need rather than being too targeted and too closed-ended. And then that assumptions happen. And that's where kind of that lack of trust and just the fact that people are maybe going to be less likely to show back up at your office. So just stay open and avoid assumptions. Yeah, next slide. So in the interest of time, we'll stop to if you want to look at this just for consideration, and then the resources. But yeah, what questions do people have? I know there's the question about antibiotic resistance with doxypep. Thoughts about that?
Yeah, that's a great question. So the idea is that the amount of antibiotic that you're taking in the body is actually less. So if you have patients who are getting gonorrhea, chlamydia, syphilis infections on a regular basis, the amount of antibiotic that's being received and consumed each time for, like that's like a 5 to 7 day course of antibiotics or so on, that's a lot more antibiotics that a person is consuming rather than taking a 200 milligram dose once a week or twice a week. Similarly, taking the doxycycline also helps prevent consumption of ceftriaxone, which is also used in treatment. So overall, although it sounds like we're handing out doxycycline, it actually is, when you look at it as a whole, the patients are consuming less antibiotics. So you're actually decreasing, hopefully, the incidence and the rate of antibiotic resistance. The next question was, what is a safer method for chest binding? That's a fantastic question. There's a lot of resources out there that we have in our resources tab in that slide. But one of the ones that I am really familiar with and that the Rady's Children's Hospital here in San Diego loves to talk about is trans tape or T-tape. And it's specific tape that was created for the trans population and for the purposes of chest binding. It doesn't cause any, it prevents rashes, it prevents discomfort. So that's kind of at the top of my head what we would recommend when a patient comes in for chest binding support, rather than other kind of off the cuff options.
Yeah, I think sometimes people just use lots of weird ways to compress, and it's just the risks of, causing like circulatory issues or, derm problems. And I think just really being mindful that there's kind of that risk reduction. Like it's still, there's issues anytime you bind, but you can do it in a safer way by, being mindful of the type of material you use. And there's even like, yeah, kind of bra type things that can be worn that are just good material that is like breathable but still compressive. So just copied in that binding resource from Fenway, which Fenway is an awesome institute to be aware of in terms of LGBTQ health. Also UCSF, we put on the transcare.ucsf.edu. They have awesome sort of references for guidelines. So just having those kind of things in your back pocket can be really helpful.